This is Dr. James Griffith. I am the chairman of the Department of Psychiatry at George Washington University in Washington, D.C. Today I'll be talking with you about building resilience with your patients. In medical training, we learn to take histories, to do exams, to take signs and symptoms, to make diagnoses, to treat illness, to treat disease. If we can eradicate disease, we enable our patients to have good health. In this day and time, in large part thanks to the fact that we have good medications, good treatments, many of our patients have chronic illnesses, diabetes, hypertension, rheumatoid arthritis, illnesses that we cannot eradicate, we cannot cure, we can treat. We can reduce pain, we can reduce disability, but we cannot cure. So our patients often are living long lives in the ongoing presence of chronic illness. So the talk today is about how to help patients stay strong. Resilience basically means psychological strength. It's the ability to survive despite adversity. And adversity is not just illness. Adversity can be poor schools for one's children. It can be insufficient income. It could be not having good access to medical care. It can be many different things. But how to stay strong in the face of adversity. And when possible, how to grow stronger. There's an old saying that what doesn't kill me makes me stronger. That's what we strive for. But for many of our patients, it's a struggle not to grow weaker through the wear and tear. So, adversities faced by medical illness, much is about physical pain. It's about disability. It's about loss of mobilization. For our mentally ill patients, depression, much of the suffering is internal, with psychoses, disorganized thoughts, being avoided by other people, a very lonely life. These are just some of the adversities that come with mental illnesses. And to make the point, adversity is much more than illness. There's 65 million refugees in the world right now. A large percentage of the Jordanian population is refugees. To be displaced from one's home, to be displaced from one's job, career, family. These are adversities that often outweigh the fact that somebody may also have a chronic illness, but it all adds up. In fact, with refugees, much of what people suffer most from is the secondary effects, not just the traumatic situation that led to a flight from their home, but unemployment, loss of social status in the new place to live. Often there's an increase in relational conflicts. But whether the pile up is from traumatic events in one's life, or whether it's from physical illness, or whether it's from mental illnesses, the pile up, the accumulation of stressors often leads into what is best termed as demoralization. The feeling is despair, the condition is demoralization, where hope, desire for a future wear away, disappear. People often turn to unhealthy health habits, poor diet, not sleeping well, not getting exercise, and this in turn can lead into deteriorating health and relationships as a consequence. So, this part of the talk is not about mental illness. That if one gets a diagnosis of cancer, if one breaks a limb and is unable to work, the sense of threat leads to fear. That's normal. Often there's much about being medically ill that you feel alone and isolated from other people, and there's loneliness, there's grief from losses. It's when these stressors pile up and a person feels like I'm not able to measure up, I'm not able to meet the demands of coping, either what I expect of myself or other people expect of me. This feeling helpless, hopeless, unable to cope when facing overwhelming hardships, which include but are not limited to the hardships of illness, is what we mean by demoralization. So, demoralization is not a mental illness. It's how a normal person feels when facing overwhelming circumstances. But because demoralization is often the consequence of living with a chronic medical illness, it's of great importance, for physicians because it leads into poor health habits, not attending to one's self care, missing appointments, not coming to seek help from the doctor, not taking medications correctly. So, what resilience is about is that there are things that people can do that help them sustain hope, even when facing very hard circumstances. And hope is the best antidote for demoralization. So, we'll be talking about resilience factors that enable a person to stay hopeful, even though the person is still facing extreme stress and a lot of hardships. I was asked to see, as a psychiatrist, a patient in the hospital. His doctor was an internist. Patient's 71 years old. For 20 years, he's had diabetes. With this, he's had loss of vision. He'd had an episode of renal failure that had to require dialysis. Through all this, he was able to work. He was able to care for his family. But about 2 years ago, his disabilities were too great and he was unable to keep working. His work was that of a cook. At the time I saw him, he had required a below the knee amputation due to peripheral vascular disease. Well, his doctor now worries that he's giving up. He's becoming careless in monitoring his blood glucose. It's as though he's no longer able to mobilize really a will to live. Now, with this kind of history, the first thing you'll think of is he depressed? And that's a good question. Uh, his age group, the correlation with medical illness, the loss of self care, these are all things that one would expect to see with depression. But depression and demoralization are important to distinguish from each other. The reason is, in large part, is because depression responds well to antidepressant medications, but demoralization does not. Most of what you'll do for demoralization is helping a person mobilize strengths and, to the extent you can, to unload some of the stressors. So, a first step in evaluating a patient like this is to distinguish, does he have depression as a psychiatric disorder? Is this demoralization is just a normal human response to overwhelming stress? It can be both, but if it is both, we need to respond to each side of it. And, thinking about, in primary care, visits are brief, do not have the luxury that I would have as a psychiatrist of maybe spending an hour with someone. So let's look at some of the shorthand ways that you can use to get a rough guide as to, should I treat this person as somebody with depression as a psychiatric illness, or someone who's just demoralized as just a normal stress response. Well, there are four markers really in the office or at bedside that suggest that someone in fact has depression as a psychiatric illness. Probably the major one of these is anhedonia. A person is no longer able to feel pleasure from things that should be pleasurable. The question I often ask is, are you still able to enjoy things? If you do something that you should be able to enjoy, are you able to feel it? If a person is turning a lot of thoughts over guilt, feeling like I'm a failure, I've let people down, I should be punished, this goes more with depression. Loss of self worth, or if there's suicidal thoughts. Now, these are not 100%, but if these four items are here, then that indicates much more likely that this should be treated as depression. The person needs to be on an antidepressant. They may need referral for someone who can do some appropriate psychotherapy interventions, usually with cognitive behavioral therapy. In addition to asking these questions at bedside, it's useful to use a scale that's been put to the test and shown to have empirical evidence that it can select out depressed patients. The one in the office, which I'll show here, is the PHQ-9 because it just has 9 questions. This could be filled out in the office. One of the nurses could get the patient to fill it out before meeting with you. The most reliable one is the Hamilton Depression Scale, which is what I would use, but it has 17 questions on it, and you have to ask those questions. So this is a lot more that you often could do in, say, a 10 or 15-minute visit. Uh, in addition to getting some quantified depression assessment scale, finding out from the history has the person had severe episodes of depression in the past. If so, it's more likely that this episode is depression. Is there a family history of mood disorder? Depression tends to run in families to a great extent. If you have a family history of severe depression, or more importantly, if there's a family history of mania, where people have mood elevation and racing thoughts. Or if there's a past history that this is someone in the past who's responded well to an antidepressant medication. Well, these are 5 lines of inquiry that can be quickly assessed in a visit that may tilt you toward a judgment that it's depression. Now, the other side of it, if the person is demoralized and it's not mainly depression as a mental illness, usually the capacity to enjoy pleasure, to respond, if someone comes to visit you've been looking forward to, if you get some good news, if you do a hobby that you enjoy, then you can feel pleasure with it. Often with demoralization, a person feels like I'm not measuring up, a term that's often called subjective incompetence. I'm not able to meet my expectations or what other people expect. And demoralization can be helped, but the way you do it is, which we'll get to in a moment, is to help people mobilize inner strengths. And probably the most reliable way is supportive relationships. If you do a depression scale, usually demoralized patients will only have mild elevations, not extreme ones. And as I've mentioned before, very importantly, antidepressants don't help demoralization. Even if the person says they feel depressed, if you go through the whole set of questions and conclude it's demoralization, it's unlikely that they will get better with an antidepressant. So here is the PHQ-9. You can download it off the internet. It's designed to be a self-report instrument that your patient fills out, although you can have your nurse or yourself, ask the questions. But it's a good instrument for identifying somebody at risk for depression, but you do need to look at the whole picture, all 5 criteria on the earlier slide, and make a judgment. If you do decide that this is depression, just some of the basics, we won't go much into this, but all the antidepressants on the market can generally be regarded as having about a 70% response rate if your diagnosis was correct in the first place. Response means it reduces symptoms. It doesn't mean that it gets rid of all of Since we don't have good criteria for asking the question, what's the best antidepressant, we rely more on trying to match side effects to your patient's medical status. So, with this patient, with diabetes, with peripheral vascular disease, uh, we would like to have an antidepressant that won't have, say, postural hypertension as a side effect, that won't have um, severe anticholinergic symptoms as a side effect. If you have had MH-GAP training, they will recommend a serotonin reuptake inhibitor as first choice. This could be fluoxetine, escitalopram, citalopram, sertraline. Bupropion is not an SSRI, but it has few side effects and is actually of a good choice, first choice, for elderly patients. So, with this brief comments about depression, let's go back to demoralization. Antidepressants aren't going to be useful. What we'll need to do is to work with the patient to engage his or her capacities to be strong in the face of adversity, in the face of stress. Now, you can think of human beings as sort of having two gears, that when you face an obstacle, an adversity, pain, and suffering, you either can move forward, engage with it, problem solve, deal with it, or you can try to avoid, back away, or submit. Now, most of the discussion about resilience is how to help people move forward, engage, not avoid, even if they can't get rid of the obstacles that they're facing. I'm briefly going to lay out what I think of as sort of three strategies that you can use. And with any particular patient, you just say, you try to figure out which one of these may work best. The first is to discern what is your patient's best strength for coping. Usually you learn this by asking questions about how they have coped when they, in the past, have encountered adversities. The second strategy is that there has been a good bit of research done on resilience, and from some of the best studies, the next couple of slides will have a list of about a dozen different resilience factors that usually, these are ones that tend to operate across a big range of people. And then finally, the third strategy is help your patient to utilize methods for strengthening emotion regulation. Emotion regulation refers to the ability to calm yourself, to quieten yourself when you're upset. It usually is the case that if you can improve emotion regulation, secondarily, it will improve resilience and help your patient have a better capacity to stay hopeful in the face of adversity. So let's return to our 71-year-old patient who suffered with diabetes for 20 years. He's had loss of vision, he's had renal failure. Now he has a below the knee amputation. Unable to work for the past 2 years, his doctor worries that he's giving up. He's not taking care of his health, he's not monitoring his glucose. Now, if we go through these three strategies one at a time, we can see is one of these sound like it would be useful to use with him. What is his best strength for coping with adversities? Well, the best way to learn about this is to go to the past, find out what have been difficult times in the past he's gotten through, and to listen carefully for how he did it, and to see whether there's a way to bring that learning to the present situation. So I might talk with him about past episodes with his diabetes. It's a hard illness. What carried you through? What kept you from giving up? Let's suppose that he says, my family. I was determined not to leave them bereft. Well, then I would want to know, who's in his family now? How often does he see them? Tell me about your grandchildren. What do you think you've most contributed to your grandchildren's lives? If it was family that carried him through in the past, then I would orient our conversations now to his family and how he's still devoted to them, how they still need him. Someone else might say, I feel like God has a plan for my life, a purpose for me to live. I need to continue living all the days that have been given to me. It could be religious faith. For someone else, they might say, in many ways, it'd be easy to give up, but there's still important things in my life I need to do. My work is not finished. So, whatever I learned from the past, I would take that theme and try to bring it to the present situation for him to turn to that now as a way of recovering his ability to cope with the new adversities of diabetes. With elderly men in particular, it sometimes is a good strategy to ask, in your adult life, what was your best year? And in the U.S., there's an expression, when were you at the top of your game? To learn about what did he do in his work, what made him good at it, what were the sports he enjoyed, what was the music, and say if soccer was his sport, then in my conversations now, when he comes in, I would pick up soccer, talk with him about that, World Cup, what are the rankings. But going back to when he was at his best and drawing from that to inform our conversations now. Now, I mentioned that there's been a lot of research on resilience, and I'm just going to go through about a dozen factors that identify people who tend to be resilient when they're in hard circumstances. And then we can ask, is there any one or two of these that we might be able to apply to our 71-year-old patient? The first is utilizing a model or mentor. It's said from the research that essentially every resilient person has models, has mentors. Uh, Sometimes a model could be, someone that you admired when you were growing up. It could even be someone from, a figure from the Quran or from literature, but someone who for you is the person you would want to emulate. So resilient people have models that they follow. Resilient people tend to be optimistic. They're realistic. They don't pretend things are other than the way they are, but given the set of facts, they take a stance of expecting there may be something good that can happen. Humor. Resilient people tend to be able to take an ironic or even a humorous view of their situation, even when it's sad or painful. A moral compass. This is an expression that really came out of some of the American prisoners of war, that having a real clear sense of right or wrong, good and bad, what is good, what is evil. People who are resilient tend to have a very clear sense of, uh, what's being termed here as moral compass, a clear sense of right and wrong. Social support. In a lot of the literature, this has been identified as probably the most important one. But are there intimate, close relationships that you can turn to? Uh, Love relationships, confiding relationships, being a family member or a member of a team. altruistic relationships, which actually is number 6 to split that one out. Being able to give to other people. Um, having a history of being somebody that just faces hard things, in particular, facing fear, not avoiding it. Training. This has been identified as one of the biggest ones that if you have a strength to practice it, practice it, practice it. Um, a history of growing stronger through encounters with adversity and strong sense of meaning and purpose. Now, these are factors that identify resilient people, and the question would be with our 71-year-old, is there anyone that we could pull out and work with him to do more of in his life? Now, I will say that the reference here is a book chapter that Dr. Lisa Catapano on my faculty and I wrote that goes into this with a lot more detail, which we are glad to send a PDF if anyone is interested in reading more about this. But just for the exercise, let's look at this list. Maybe one item I'd pull out might be social support. So if I wanted to strengthen social support in the life of our 71-year-old patient, I might start just by asking who knows what you're going through. On your really bad days, who do you turn to? Who's in your family? When do you see them? If I find out that there are relationships that have been important in the past, but he's not in contact with, I often would arrange for that person to come. Or even to get on the phone. Or with one patient I can remember in our hospital, uh, his small son was not able to visit him, so we arranged for him to Skype, on a iPad, so it could be in contact. Who counts on you and who do you count on? So if I'm working with him on social support, I'm trying to get clear about who are the important relationships in his life. Is he in contact? If he's not, I try to arrange that. Uh, try to just add more relationships. Um, are there support groups? Um, but you try to just thicken the relational contact that the person has if you're going to work with them on this as a resilience factor. Another one I thought of might be altruism. He's disabled, he's not able to work. Would there be a volunteer role he could take? Uh, actually, I know in the US that there are programs for the homeless, soup kitchens, where his skill as a cook, might be of a lot of value, even if he can't do it enough that he could do it as a paying job. Or could he teach cooking? Um, and often it can be helpful in terms of altruism to get an ill person connected up with, if not a person, then maybe a pet. In the U.S., there's a big movement in many ways about connecting even patients with psychiatric illnesses with um, usually a dog, but it could be another animal, or even a garden. But in some way, doing caretaking, giving, turns out to be a real strong resilience factor for helping people mobilize hope in their lives. Now, the last strategy was emotion regulation, the ability to soften strong emotions without being reactive to them. And when emotion regulation is strong, usually morale stays strong, a person can stay more hopeful. So, if I often clinicians recommend to patients, prayer, mindfulness meditation, yoga, aerobic exercise. But what I most like to do myself is just to learn from the person's life that over the years, when you're upset or stressed, what has worked best to calm yourself, to restore a sense of peace and equanimity? What best gives you a sense of deep joy? In whose presence do you most feel a sense of comfort? Often, relationships are the most powerful way for strengthening emotion regulation. What is your favorite activity or hobby? If you can find something that really is pleasurable and fun, that often strengthens emotion regulation. So, in summary, these are three strategies. Try to figure out what your patient's best coping strength. You'll usually learn this by talking with them about what's got them through hard times in the past. This list of 11 resilience factors that I put up that come from research, if you can find a way to help somebody introduce one of those into their life now or to do more of it, that can be effective. And adding practices, activities, relationships that bring about strong emotion regulation secondarily often is a very good avenue for strengthening hope, countering demoralization. And, where we began with this is that demoralization matters because when people become demoralized, they stop taking care of themselves, whether it's coming for help, taking the medicines correctly, doing health behaviors like diet, exercise, and so forth. So, resilience means facing, moving forward, engaging with problems and adversities, not avoiding, backing away, or submitting to them. And, in our discussion, we talked about the difference between demoralization and depression. If it's depression, you often are going to need to add the medical treatment with an antidepressant. With demoralization, it's mostly going to be working with somebody to move forward, engage, not avoid or back away. So, just as a final recommendation, you might think about this. I know that in primary care, you may have a lot of visits that may be only 5 or 10 minutes. Patients come with symptoms, they're expecting to get a prescription. So, when you give a prescription for a medication, do that, but see if you can add one resilience building intervention to each visit when your patient has a chronic illness that they're going to be living with for years ahead. So hopefully this is helpful and was in Jordan a year ago and would look forward to coming back again and learning more about your work there. Best wishes. I'm briefly going to lay out what I think of as sort of three strategies that you can use. And with any particular patient, you just say, you try to figure out which one of these may work best. The first is to discern what is your patient's best strength for coping. Usually you learn this by asking questions about how they have coped when they, in the past, have encountered adversities. The second strategy is that there has been a good bit of research done on resilience, and from some of the best studies, the next couple of slides will have a list of about a dozen different resilience factors that usually these are ones that tend to operate across a big range of people. And then finally, the third strategy is help your patient to utilize methods for strengthening emotion regulation. Emotion regulation refers to the ability to calm yourself, to quieten yourself when you're upset. It usually is the case that if you can improve emotion regulation, secondarily, it will improve resilience and help your patient have a better capacity to stay hopeful in the face of adversity.